got some protein jokes for you today. You ever wondered why did the bodybuilder buy expired protein powder? Because there was just no other way. And why didn't the biochemist laugh at the antibody jokes? Because he was humorly immune. Hi everybody, it's Dr. Ryan here. Hope you and your folks are well. Thanks for joining me even as we dissect plasma cell dyscrasias today. If you haven't yet subscribed to my channel, I encourage you to do so that you don't miss any exciting new content in the beautiful discipline of internal medicine that I offer on this channel. God bless you. Here's an outline of our topic for discussion today. We're going to be breaking down plasma cell dyscrasias, introducing the topic, and then with specific emphasis on multiple myeloma. We're going to tease apart the etiologies behind the plasma cell dyscrasias, looking at patient presentation, signs and symptoms, then looking at differential diagnosis, the diagnostic evaluation, treatment and management modalities, prognosis, and then we're going to end off with scripture. God bless you. Thank you so much for joining me. Guys, put your helmets on, fasten your seatbelts. Here we go. 58-year-old man is evaluated for a sudden onset cough with yellow sputum production and dyspnea in the emergency department. Now, aside from systemic hypertension, he is otherwise relatively healthy. His only medication is amlodipine. Now, chest x-ray shows a right upper lobe alveolar infiltrate, and labs are notable for a urea of 19 millimole per liter and a creatinine of 304 micromole per liter. So he's got significant renal impairment. Corrected calcium of 3 millimole per liter, so that's hypercalcemia, and an albumin of 19 milligram per deciliter. So he probably has a wide globulin fraction. Sputum culture grows our beloved strep pneumonia. Which of the following tests will confirm the underlying condition predisposing him to pneumococcal pneumonia? Is it A, bone marrow biopsy, B, CT of the chest, abdomen, pelvis with contrast? Is it C, HIV antibody, D, sweat chloride testing, or E, videoscopic swallowing study? Wonder. Guys, plasma cell disorders are a diverse group of disorders of unknown etiology. Nobody knows why it's there, but we know it's there. Characterized by, firstly, disproportionate proliferation of a single clone. There's no polyclonal, it's monoclonal proliferation of beta cells, B cells. Presence of a structurally and electrophoretically homogeneous, that's what we call monoclonal, immunoglobulin or polypeptide subunit in the serum, in the urine, or sometimes both. Right? Multiple myeloma specifically is a cancer of plasma cells that produces monoclonal immunoglobulin and invade and destroy adjacent bone tissue. Common manifestations to look out for multiple myeloma are bone pain, renal insufficiency, hypercalcemia, anemia, and recurrent infections. I'm sure most of us know the maxim CRAB, right? So C is for calcium, hypercalcemia, R, renal impairment, A, anemia, and B is bony affectation, all right? And remember that there are 7 entities that we talk about when we talk about plasma cell dyscrasias, right? Multiple myeloma, monoclonal gammopathy of uncertain significance, plasmacytoma, all right, the so-called POEMS syndrome, Waldenstrom's macroglobulinemia, amyloidosis, and cryoglobulinemia. They're all the plasma cell disorder cousins. Now, diagnosis of multiple myeloma typically requires demonstration of an M protein, which is sometimes present in the urine and not the serum, but it's really absent entirely. So if you don't find it in the serum, you may find it in the urine. If you don't find it in the urine, you may find it in the serum, but it's rarely ever absent completely. And either lytic bony lesions, light chain proteinuria, or excessive plasma cells in the bone marrow. Right? A bone marrow biopsy is usually needed to clinch the diagnosis of multiple myeloma, and specific treatment often includes some combination of conventional chemo, corticosteroids, and one or more of the newer agents such as bortezomib, carfilzomib, lenalidomide, thalidomide, pomalidomide, or elotuzumab. All right. High-dose melphalan followed by autologous peripheral blood stem cell transplantation may also be used. Okay, so the types of plasma cell dyscrasias we touched on, but multiple myeloma by and large probably the commonest at 75% of the time, where we have a malignant clone that extends from a pre-beta cell to a plasma cell stage of differentiation. It may produce immunoglobulin G 60% of the time, immunoglobulin A 20% of the time, or light chains some 15% of the time. Then we have Waldenstrom's macroglobulinemia at 20% of the time, which involves the proliferation of plasmacytoid lymphocytes. It's a cell type that occurs just earlier, right, in the precursor chain than plasma cells. Produces immunoglobulin M. It's now classified as lymphoplasmacytic lymphoma. Then we got heavy chain deposition disease, which produces immunoglobulin A, IgG, or IgM heavy chains, right? Then we get light chain deposition disease, which is kappa or lambda light chains. Then we get AL, which is primary amyloidosis, which produces lambda or kappa light chains. What's a pathophys, guys? So MGUS refers to monoclonal gammopathy of uncertain significance, occurs in about 2% of the population over the age of 50 and about 3% of the population over the age of 70. The rate of transformation of MGUS to a malignant plasma cell disorder in the way of multiple myeloma, Waldenstrom's macroglobulinemia, primary amyloidosis, B-cell lymphoma, or chronic lymphocytic leukemia is about 1% per year. Risk factors include personal risk factors like old age, has a predilection for among the black race, diseases like chronic polyclonal hypergammaglobulinemia, and treatment like radiation, right? This is a beautiful diagram taken from Harrison's, which is basically illustrating to us the pathogenesis of multiple myeloma. So in multiple myeloma, cells interact with bone marrow, stromal cells, and extracellular matrix proteins via adhesion molecules, triggering adhesion-mediated signaling as well as cytokine production. This triggers cytokine-mediated signaling that provides growth, survival, and anti-apoptotic effects, as well as development of drug resistance. Additional bidirectional interactions lead to inhibition of osteoblast and increase in osteoclast activity, which then leads to the bone-related issues that we see in myeloma. Similar interactions with immune microenvironment leads to augmentation of tumor-promoting immune responses and suppression of tumor-protective immune responses, overall allowing myeloma cell growth. Okay, this is illustrated here. How do patients present, guys? So pancytopenia commonly, and that will manifest with weakness, fatigue, infection, gingival bleeds, ecchymoses, epistaxis, menorrhagia on account of the thrombocytopenia, right? And of course, you get the leukopenia, the lymphopenia, and the anemia. Increased polyclonal protein, which makes you immunoparetic. Your immune system is weak, and you're prone to infections due to the decreased normal IgG and hyperviscosity syndrome. We'll touch on hyperviscosity syndrome in a subsequent slide. Lytic bony lesions, we explained that, right? Which leads to pain and fractures. Hypercalcemia, which will give one weakness. Nausea, abdominal pain, polyuria, altered mental status. You know, stones, bones, psychic bones, abdominal groans. You know that maxim there. Neurological issues in the way of peripheral neuropathy on the back of amyloidosis, plasma cell infiltration of the meninges, cord compression, watch out, radiculopathy from vertebral osteolytic lesions, and possible plasmacytoma. You're also get renal failure, and renal failure on account of many reasons. First up, pre-renal, because of nausea and vomiting and renal vein thrombus. Renal, there's a whole truckload of causes as to why the kidneys are affected in multiple myeloma and in plasma cell dyscrasias. So you get myeloma kidney because of tubulointerstitial damage from light chain absorption at the level of the proximal tubule. Plasma cell infiltration of the kidneys, Bence-Jones or Cast nephropathy, amyloidosis because of lambda light chain deposition. Then you get light chain deposition disease from the kappa light chains, hypercalcemia, which can cause nephrogenic diabetes insipidus, cryoglobulinemia, pyelonephritis, sepsis. So kidneys are hit because of many reasons. And then, of course, you've got post-renal causes, which includes renal stones on account of increased uric acid and neurogenic bladder. Of course, you get constitutional features as well, like anorexia, fever, weight loss. This is a malignancy after all. Diagnostic evaluation, guys, if you encounter a patient in whom you think they have a plasma cell dyscrasia or multiple myeloma, you want to do a full blood count with a peripheral smear, urea electrolytes, calcium, magnesium phosphate, beta-2 macroglobulin, and serum viscosity, quantitative immunoglobulins. So send the blood off for immunoglobulins and also for free light chains as well, serum free light chains. Liver function, including albumin, because you want to quantify your globulin fraction. Then you do your SPEP and UPEP, serum protein electrophoresis, urine protein electrophoresis. It's important that we do both because sometimes the monoclonal gammopathy will declare in the urine and not the serum. Sometimes in the serum and not the urine. It's good to do both, right? You can also do a formal 24-hour urine collection for Bence-Jones proteinuria. Do your serum-free light chains like we mentioned. Okay, this is taken from Harrison's, guys, and it's basically illustrating for us the diagnostic criteria for multiple myeloma, myeloma variants, and monoclonal gammopathy of undetermined significance, MGUS. So in MGUS, monoclonal gammopathy of uncertain significance, it has to do with the quantification of your monoclonal protein, right? In your serum is less than 30 grams per liter. The clonal bone marrow plasma cells on a bone marrow is less than 10%. And we got the absence of myeloma-defining events, which is CRAB features, right? Or amyloidosis that can be attributed to a plasma cell proliferative disorder. Smoldering multiple myeloma, which refers to asymptomatic myeloma, both criteria must be met. A serum monoclonal protein, being IgG or IgA, of above 30 grams per liter. This is how it departs from MGUS, right? It's above 30 grams per liter, whereas MGUS was below 30 grams per liter. Or you got a urinary monoclonal protein of above 500 milligrams per 24 hours, and or a clonal bone marrow plasma cell, population of 10 to 60%. But note that you have the absence of myeloma-defining events or amyloidosis. Now, symptomatic multiple myeloma, it refers to clonal bone marrow plasma cells or biopsy-proven bony or extramedullary plasmacytoma, and any one or more of the following myeloma-defining events. So we have evidence of one or more indicators of end-organ damage that can be attributed to the underlying plasma cell proliferative disorder. And looking at the CRAB features, right? Hypercalcemia, renal insufficiency, anemia, bony lesions, and any one or more of the following biomarkers of malignancy, being a clonal bone marrow plasma cell percentage of a whopping above 60%, involved to uninvolved serum free light chain ratio of above 100, hence the importance of quantifying your serum free light chains, and you got more than one focal lesion on MRI, which is not readily available modality. Non-secretory myeloma, in this particular entity, we have no M protein in serum or urine with immunofixation, bone marrow clonal plasmacytosis above 10% or plasmacytoma, and you got your CRAB features, right? Then, of course, we talk about the entities of solitary plasmacytoma, which is biopsy-proven solitary lesion of bone or soft tissue with evidence of clonal plasma cells. Normal bone marrow with no evidence of clonal plasma cells. That's important. Normal skeletal survey and MRI or CT spine and pelvis, except for the primary solitary lesion, and absence of end-organ features or CRAB features, right? Poems is a beautiful, it's very poetic. Not really, guys. It's quite devastating. Poems, all of the following four criteria must be met. P is polyneuropathy, O is organomegaly, right? E is endocrinopathy, M is metabolic issues, and S is skin, right? So you got monoclonal plasma cell proliferative disorder, any one of the following: sclerotic bony lesions, Castleman disease, elevated levels of VEGF, which is vascular endothelial growth factor, any one of the following: organomegaly in the way of splenomegaly, hepatomegaly, lymphadenopathy, extravascular volume overload in the way of edema, pleural effusion, ascites, endocrinopathy in the way of adrenal, thyroid, pituitary, gonadal, parathyroid, pancreatic, skin changes with respect to hyperpigmentation, hypertrichosis, glomeruloid hemangiomata, plethora, acrocyanosis, flushing, white nails, papilledema, and thrombocytosis or polycythemia. That's Poems syndrome. This is a beautiful pattern of serum protein electrophoresis with immunofixation, and just showing us the upper panels here, right, represent agarose gel. The middle panels are the densitometric tracing of the gel, and the lower panels are the immunofixation patterns. The pattern on the left illustrates the normal pattern of serum protein electrophoresis, right? Because there are many different immunoglobulins in serum, their differing mobilities in the electric field produce a broad peak, right? In conditions associated with increased polyclonal immunoglobulin, the broad peak is more prominent, right? So this is basically your immunoglobulin G, A, M, kappa, and lambda chains, okay? So we said that in monoclonal gammopathies, the predominance of a product of a single cell produces a church spire sharp peak, usually in the gamma globulin region, all right? Which we can appreciate in the panel here, a monoclonal IgG lambda kind of peak. For example, immunofixation identifies the type of immunoglobulin. For example, normal and polyclonal increases in immunoglobulins produce no discrete bands. However, the right panel shows distinct bands in IgG, right? And lambda lanes. There we go. There we go. Confirming the presence of immunoglobulin G in lambda monoclonal protein. All right, here we can see under the microscope on a bone marrow biopsy, multiple myeloma. The cells bear characteristic morphological features of plasma cells, round or oval cells with eccentric nucleus composed of coarsely clumped chromatin, a densely basophilic cytoplasm, and a perinuclear clear zone containing the Golgi apparatus. Binucleate and multinucleate malignant plasma cells can be seen. Okay, guys, how are you going to work the patient up? Okay, going on to imaging. Ideally, you want to do an MRI or a positron emission tomography, CT scan, PET scan. If not available, use a skeletal survey. Please note the standard bone scan does not play a role in routine myeloma staging. Bone marrow biopsy, obviously, to quantify the plasma cell population in your bone marrow, and that helps in the definition, as we mentioned, of MGUS versus smoldering versus asymptomatic multiple myeloma. Please note, light chain myeloma in 20% of the time may have a normal serum protein electrophoretic pattern. Urine Bence-Jones protein, which is UPEP, is required to detect your hepatoproteinemia. Non-secretory myeloma in 3% requires bone marrow biopsy for diagnosis because you're not going to pick up any peripheral protein, right, on your electrophoretic studies. Diagnostic clues, guys, symptoms that make you suspect myeloma is the presence of tissue impairment, suggests either multiple myeloma, usually a high M protein, or amyloidosis, where you get usually a low M protein. They are cousins. Remember, plasma cell dyscrasias, there's 7 different entities to tease apart. Amyloidosis and myeloma very common among those. So AL amyloidosis is characterized by insoluble toxic amyloid precursor, which is a light chain aggregates that deposit in tissues in the anti-parallel beta-pleated sheet configuration. The absence of symptoms suggests MGUS or smoldering multiple myeloma, so you don't have the crab features, right? Quantitative immunoglobulin G typically decrease serum levels of normal polyclonal immunoglobulins in multiple myeloma. However, this may also occur in the setting of MGUS. Serum M protein level, the higher the level, which is about 30 gram per liter, the greater the likelihood of multiple myeloma. Serum free light chains, guys, multiple myeloma will have a serum involved to uninvolved free light chain, which is kappa or lambda ratio of 100 or greater. We've seen this, provided the absolute level of the involved light chain is at least 100 milligram per liter. Okay, a free light chain ratio of less than 0.26 or above 1.65 predicts high risk MGUS. Bence-Jones proteinuria, the presence of monoclonal light chains, especially above a gram per day in the urine, suggests multiple myeloma. However, small amounts less than 50 milligram per day may also occur in MGUS. Imaging to assess bony involvement for patients suspected of multiple myeloma. Patients with smoldering myeloma may require imaging, including PET-CT, low-dose whole-body CT or MRI of the whole body or spine pelvis. Right, so this is just putting it in other words, what we've just discussed in terms of our investigative workup, taken from Harrison's, right? So we stratify the investigations into those who evaluate for clonal plasma cells, those who evaluate clonal hepatoprotein, those investigations to evaluate your end-organ damage, your crab features, and your imaging, those for risk stratification and specialized investigation in selected cases, right? And here we're just looking at bony lesions in multiple myeloma. In the image on the left, we have the skull demonstrates the typical punched out lesions. That's what we're looking for, guys. Punched out lesions, characteristic of multiple myeloma. Look at that. And the lesion represents a purely osteolytic lesion with little or no osteoblastic activity. And here we see a PET-CT showing multiple fluorodeoxy glucose, which is FDG, avid lesions in the skeleton, right, which is a panel on the left. We can see it lighting up there, with a resolution on achieving complete response. Look at this. This is post-intervention in the way of chemotherapy. So here's our treatment algorithm, guys, for multiple myeloma. Okay, let's just get my pen in there. So if you've got a newly diagnosed case of myeloma with myeloma defining events, hypercalcemia, renal impairment, anemia, bone affectation, if indeed yes, then we progress down here. But if no, it could be smoldering myeloma and no therapy except on clinical study, regular follow-up. If you do have the appearance of myeloma defining events, you come back to the left-hand side. And here, the next question is the patient transplant eligible or transplant ineligible? If they're ineligible, you do induction therapy with these agents here, right? So if we were to go to our a beautiful key at the bottom, this we mentioned these, right? So it's bortezomib, it's cyclophosphamide, it's dexamethasone, or some combination, right? If the patient is transplant eligible, then we consider these agents as mentioned. If there's no response, consider an alternative regimen. And then essentially, if they are candidates for transplant, and if there is a response, you want to do a transplant consideration and maintain them. If not, you just maintain on those regimens. And that's basically how we approach, myeloma. So this is basically the domain of the oncologist or the hematologist, but just to know the standard therapeutic agents in myeloma. So we got different flavors, different classes, immunomodulatory drugs like thalidomide, lenalidomide, pomalidomide, proteasome inhibitors like bortezomib, which is one of the new kids on the block, carfilzomib, antibodies like daratumumab, elotuzumab, right, selective inhibitors of nuclear export like selinexor, histone deacetylase inhibitors, alkylating agents like melphalan, cyclophosphamide, which are probably some of the older chaps, cellular therapy, and of course glucocorticoids, dexamethasone, prednisone, but Dexa is probably the way to go. All right, just to cover a couple other specific entities, guys, just touch on the other plasma cell dyscrasia as we mentioned. Solitary plasmacytoma of bone speaks to a single osteolytic bony lesion with a limited amount of monoclonal protein in the serum or urine and absence of tissue impairment. Radiation is usually the treatment of choice and may result in cure, 80% chance of developing chronic myeloma. Amyloidosis, we covered in a previous video, so I encourage you to go and check that out. But workup includes abdominal fat pap biopsy, abdominal ultrasound, echocardiogram. POEM syndrome we already alluded to, which is osteosclerotic myeloma with polyneuropathy, organomegaly, endocrinopathy, monoclonal protein skin changes as mentioned, right? Hyperviscosity syndrome also occurs when your immunoglobulin G content is above 70 gram per liter or IgA above 50 gram per liter. And symptoms include much the same as the other plasma cell dyscrasias. However, you get fatigue, changes in mental status, focal or non-focal neurological changes, visual changes along with retinopathy, angina pectoris, bleeding disorder, cryoglobulin, Raynaud's phenomenon, and pruritic eruptions on exposure to cold because of the increased viscosity of the blood on account of your increased immunoglobulins, right? So guys, coming back to our clinical case, we had a 58-year-old man who comes to you with sudden onset cough. He's got pneumococcal pneumonia, right? He's immunopyretic. Why is he immunosuppressed? He's otherwise healthy. He only takes amlodipine. He's got renal impairment. He's got hypercalcemia. He's got a raised globulin fraction. Looks like, smells like myeloma. We need a bone marrow biopsy, okay? Because the patient presents with pneumococcal pneumonia and evidence of crab features, not RCAP, crab features, sorry, and a wide globulin gap which suggests that he may have an M protein. These findings are classic for multiple myeloma. Bone marrow biopsy will confirm the presence of clonal plasma cells and define the quantity which will stratify our treatment options, right? Okay, my friends, let's just talk about scripture today. The Bible tells us in the book of Psalm chapter 34, verses 7 through 8, the angel of the Lord encamps around those who fear him and he delivers them. Taste and see that the Lord is good. Blessed is the man who takes refuge in him. So we know that the fear of the Lord is the beginning of wisdom. Because we don't want to displease the Lord. We don't want to incur his indignation. David said, Lord, clean hands and a pure heart is what I desire, right? And we know that the Lord is good. He's a wonderful Heavenly Father. Blessed is the man who takes refuge in him. And I pray that will be the desire of our hearts, to seek the Lord in everything, every day, to come before him, to sit at his feet, and to take refuge in the Lord our God. Here are my references, guys. If you enjoyed this content, please hope that you will subscribe to my channel, like and share my videos. Thank you so much. I truly appreciate your support. We've got a couple of interesting topics coming up. Looking forward to seeing you there. You can catch me on Facebook and Instagram and on TikTok. Just search for Internal Medicine, Algorithms, and Mnemonics. Yes, have yourself a lovely day.